Hi, everyone, and welcome to the first Pulmonary Grand Rounds in December. I am very honored to introduce today's speaker, and we will be hearing from Dr. Jenkins. So Dr. Jenkins has been here before. When were you here last?
I don't think I've been to Yale before.
Really?
No, I think this is my first visit.
So I had an entire constructed interaction with Dr. Jenkins in my head that apparently never happened at Yale. But I was recalling you in my messy office, but that must have been another very accomplished British ILD researcher. As we know, Dr. Jenkins is an NIHR research professor, and he holds the Margaret Turner Warwick Chair of Thoracic Medicine at Imperial College London. He is based at the Guy Scadden Building at the Brompton campus, where he is head of the Margaret Turner Warwick Center for Fibrosing Lung Diseases at the National Heart and Lung Institute. Professor Jenkins holds honorary contracts with the Royal Brompton and the Harefield NHS Foundation Trust with the Imperial College Healthcare NHS Trust. It's very, very royal and imperial sounding and is very impressive. His research is really interesting, and we're going to hear some great updates today. His research focuses on interstitial lung disease, obviously, and pulmonary fibrosis in particular. He works to understand the biological basis for the development of fibrosis and aims to translate this to improved outcomes for patients. He is the principal investigator of many observational studies, including the PROFILE study, the Injustice study, the UK ILD post-COVID IL-19 study, and as well as others. He is the Pulmonary Fibrosis Working Group Lead for the Genomics England Clinical Interpretation. You need a like really good acronym for that. The Genomics England Clinical Interpretation Partnership in Respiratory Medicine, the FOSP COVID study, and the HEAL COVID platform study. He is a very awarded speaker. He was awarded the ERS Gold Medal in ILD in 2020. And in 2022 became Fellow of the European Respiratory Society and appointed President of Action for Pulmonary Fibrosis and the BTS Meritorious Service Award for 2022. And today and tomorrow he's here, and I think Friday a little bit too, to share his experience and knowledge with us. So even if you're not interested in ILD, I really hope that everybody will come out and listen, because if you look at how ILD has changed over the last 10 to 15 years, it's really remarkable. Dr. Jenkins has been at the forefront of this, so we're really fortunate to hear from him today. Thank you.
Well, thank you very much for that kind introduction. No, it's a great honor and privilege to be here, and I'm really glad to finally been able to make it. So what I'm going to talk about today are interstitial lung abnormalities. And spoiler, I think I'm not particularly happy with our current approach and nomenclature and anything about them. So I hope I will challenge what people are thinking. And if you disagree with me, please just shout out as we go. I think that would be helpful. There's some accreditation stuff here that you might need to document. There's a number in bold which looks important, 53890. So what I'm going to do in the next 45 minutes or so is I'm going to give a couple of case histories, and these are patients I have seen in the last year, and then discuss what I think and what other people think an interstitial lung abnormality is. And then I'm going to ask the question, I mean, I can give you the answer now. I don't think we should screen for ILAs, but I'm going to ask the question, should we screen for ILAs, as that's in the document? And then I'm going to talk about risk stratification, because I think that's important. And finally, I'm going to talk about how we might manage them. And I think this is all really important from a biological perspective, because I think a lot of the work I'm focusing on biologically is the onset of fibrosis, rather than trying to reverse fibrosis once it's happened. And actually, this gives us a really useful sort of structure for doing it. So the first case I saw was an 82-year-old woman who went to her primary care physician with a 12-month history of rapid weight loss. She's lost 2 stone in weight. Nothing else of note was documented. That was what her primary care physician was faced with. So no previous medical history at all, no other symptoms, no medicines, which is remarkable for an 82-year-old woman to be on no medicines. I think that's a sign of great health generally. Never smoked, no family history. So what would the US physician do in this circumstance? Okay, I think that's pretty much what happened exactly. So they did CT, chest, abdomen, and pelvis, and then they ordered some tumor markers, which was probably not very helpful. And this is what they found. So they didn't find any tumor, but anyone want to sort of say what this is? It's a fibrotic interstitial lung disease, and it was discovered incidentally. So by definition, well, by Fleischner definition, it's an interstitial lung abnormality. Certainly, it's more than 5% of the lung. Is it something else? It is, again, spoiler alert. And we can discuss the air trapping and the honeycombing and I've only shown you the lower zones, but the upper zone predominant, so you get an idea of what it's likely to be. Interestingly, her CA19-9 came back at 256, with the upper limit of normal being 37. And her pancreatic CT, or the CT of her abdomen, was normal, and her pancreas was normal. I did get them to look at that. That was kind of helpful. So when I spoke to her, I said, "Are you sure you're not breathless?" Because there's a lot of fibrosis in that scan. And she said, "Okay, well, I'm 82. I struggled a bit to get up the stairs, but I thought that was fine." She was still able to do her yoga classes 3 times a week, and she had very little cough. She was not clubbed. Cardiovascular system was normal. She had some creps and some occasional squawks. So again, fitting with a CT which looked a lot like fibrotic HP or chronic hypersensitivity pneumonitis. I do object to the term BIP. I'd love to know what your view on that is, Robert. I think BIP as a new classification is a disaster, but I'm not going to talk about that today. Happy to talk about it at some other time, maybe over beer. This was her lung function. So her initial lung function showed an FVC of 0.92, which is low by any stretch of the imagination. She was unable to do a gas transfer. She blamed this very much on the lung function technicians and said, "Can I do it again?" And so she did it again, and she did get, as you can see, some considerable improvement. So by definition, we cannot call it progressive pulmonary fibrosis. Although by definition, it had to have progressed to get there, which is one of the paradoxes of the nomenclature that I hate. Her echo was okay, and these are data from the profile study that we published a long time ago now, and you'll see here the CA19-9. So that's 37, the upper limit of normal. Anything above that, these patients progress. Anything below that, and they're stable for 12 months by our definition of progression, which was a loss of FVC of 10% or death within a year. So I would say that by using a combination of the bleeding obvious, that she had lung function, which was very poor. She had lots of fibrosis on her scan, and she has a high CA19-9, that this is a progressive fibrotic lung disease, which looks like chronic fibrosing hypersensitivity pneumonitis. So the question is based on, she was initially an ILA, doesn't look like IPF, but there were some UIP bits on her radiology, and we couldn't call it PPF by current definition. So what is it? And this is important because if it's not IPF, we can't give an antifibrotic. If it's not PPF, we can't give an antifibrotic. But how long do I wait with someone whose FVC is already on the borderline? So anyway, you can imagine what I did. The second case is also interesting. Again, in fact, I saw him on the same day, 85-year-old man, this case. noted to have fibrotic ILA 12 years previously, and had not had any symptoms. And so this guy was an artist. He's actually, turns out he's quite a famous artist. And his studio is on the 7th floor of this apartment building. And he's been able to walk up and down his apartment, the 7 floors, for the whole 12 years. And he'd had annual follow-up in another hospital without progression, and they just watched this. And then he'd had a previous history of hypertension and atrial fibrillation, and he had a permanent pacemaker in, and he was on some anticoagulants and some cardiac meds consistent with that previous history. And he had no family history, and as I say, he's an ex-smoker. You know, most people are ex-smokers, and had some exposure to wood dust in his early life. On examination, he was not clubbed either. Cardiovascular system was fine, and he had crepitations on exam. So again, no surprises there. And then he developed a pneumonia in January, in winter, following winter virus season, treated with antibiotics, and that really took, that adjusted his symptoms considerably. He became breathless, but then started to get better afterwards, and was still able to walk up the flights of stairs to his artist studio, although he felt maybe not quite so quickly as previously. And this is his CT scan. So this is his CT scan 12 years after a diagnosis of an ILA. So again, basal, peripheral, subpleural fibrosis, possibly with a bit of ground glass, but this CT scan isn't particularly good. I don't think it was a high res, so I wouldn't want to comment on the ground glass there. His FVC in 2022 was 3.64 liters. So this was in a 80-odd-year-old man. It's pretty good, 105%. And this illustrates one of the problems, that the percent predicted FVC doesn't match with the actual drop in his FVC, because we have different algorithms. And until GINA recently been introduced, you could pretty much get whatever percent predicted you wanted based on the prescribing criteria and the patient that you saw. But by 2025, his FVC had dropped. Although according to percentage predicted, the different algorithm, it hadn't, but clearly he dropped. He lost about half a liter. So again, is this really an ILA? No, it's obviously not. It's got worse. Is it IPF, or is it progressive pulmonary fibrosis? Because it's originated, by conventional wisdom, IPF, you don't live 12 years with IPF. Therefore, can it be IPF? But it looks like IPF. He has all the clinical features of IPF. So I called this IPF. And so I treated it. And so these two, I think the reason I show these cases is because they illustrate that the ILA is your starting point for what many people is a journey of fibrosis. ILA is not an end. It's not like a diagnosis. Here you go, here's ILA, off you go. It's something that we need to do something about, and there are some options. But it's important to remember that all pulmonary fibrosis starts from normal lung. And we can see that beautifully here from this patient series of CT scans, where slowly the fibrosis gets worse. And I think sometimes we lose sight of that, because our diagnostic algorithms are very much framed in a period of time. And the lag time from injury to fibrosis is very, very long. And this is a slide that I've been using, and I think it's probably fairly accurate. The exposure that causes fibrosis is often in middle and working life. And then in your sort of late 40s, early 50s, you get these ILAs. And then we know from some wonderful data from health records that most people have 3 years of symptoms before a diagnosis of IPF is made. And then once a diagnosis of IPF or equivalent progressive pulmonary fibrosis is made, you're already on the FVC decline curve, which is usually when things are really pretty bad. And then sadly, people die. And so I think this is worth bearing in mind what this sort of time frame, because are we going to be able to change that? So what is the definition of an interstitial lung abnormality? So I quite like the Fleischner definition, which is an interstitial lung abnormality is detected incidentally on a CT scan, because it is a starting point. It's not a defined entity. And this is what practically we have to deal with. We are getting so many thousands of CT scans done for other reasons. We have to deal with these incidental findings, but it's not an end of itself. This is what we found on the CT scan. Now we have to do something about it. But this is not what everyone thinks about interstitial lung abnormalities, and I'll come on to them. But this is a problem because using the Fleischner definition, Amanda Grant-Orser out of Calgary did this excellent meta-analysis showing that 7.5% of screened populations, and this is someone at risk, so someone who has smoked, who's over the age of 50, 7.5% of these people will have an interstitial lung abnormality. Now, this is from the United States Census. Look at those graphs from 1960 to 2060. Now, I've estimated the UK, we're going to have over 1 million people with lung abnormalities, interstitial lung abnormalities. You are going to have way more. Good luck to those of you running your RD services. I mean, these numbers, if we don't make sense of what an ILA is, pretty soon are going to overwhelm all your services. And it's an issue. So what do we know at the moment? And again, these data are from this meta-analysis is 2 years old, and they really did a great job of looking at these data. So we know that ILAs are increased in older males, about 2.5 years older than someone without an ILA. Males more than females, but it's not a huge difference. There's a 20% increased risk in males rather than females. And this is, for me, fundamentally important. The lung function is virtually identical. There's a 2% difference in FVC between ILAs and non-ILAs. When they looked, so a lot of these studies that have been done didn't have lung function. So the lung function is in an ILA, in a real ILA, the lung function is normal or close to normal. And this is important when we think about moving forward, what to do about these things. So the ATS came up with what I thought, and I told them, was a very unhelpful document earlier this year. And they removed the requirement for this to be an incidental finding. And they didn't like the exclusion of high-risk populations. And they've given these reasons for removing it. I'm not going to read reason 1 out, but I don't understand what that means. I mean, it just means our radiologists aren't clever enough. I think that's what it means. It sounds like very typical ATS guidelines speak to me. ILAs can still be present in high-risk populations. I don't know if that's an ILA. Something is present in the high-risk population, but is it going to become progressive pulmonary fibrosis? And it's simpler to create a relatively broad, this was hysterical, this is just brilliant. It's simpler just to put the problem onto ILD services and get you to take everyone, because actually we don't want to deal with this. You know, these millions of people flooding to your clinics are your problem. But they did also describe some radiology differences between an ILA and an ILD, and I think this is kind of helpful, especially if you can distinguish between what having 5% in a lung zone is compared to the difference in an ILD. So clearly, if a patient has symptoms, then the ATS doesn't consider that an ILA, and I would agree with that. I think if the symptoms is probably a disease. This is important because of the difference in physiology, but if there's abnormal physiology, then it's a disease and not an ILA. The problem is, of course, we don't know what abnormal is. We don't know what normal is. I mean, I was talking to a community physician who said that anything over 80% FVC was considered by community respiratory physicians in the UK as normal. I said, that's not normal to me. Is 98% predicted normal? Probably. We know that's the difference between ILA and non-ILA. So I think there's not enough clarity about what they mean by abnormal physiology, but I still would agree with that in principle. Progressive, well, that's not helpful at the time of diagnosis. And it's also not helpful when we look at what the average progression of fibrosis is on ILA by physiology. And then the only difference between an ILA and an ILD radiologically is this, whether it's 5% of a zone or 5% of total lung volume. And I know even the radiologists are struggling to understand that. So that's the context of their recommendation for screening, which I think is a car crash waiting to happen. So these are data from the Framingham Heart Study. So these are the seminal work done by Rachel Putnam and Matt Honeyhackey. And I think, so this was 1,867 people, 6 years apart, so 2 scans. And these numbers were eye-watering. Because what they showed here was only 35% of people had a normal scan both times, which means that 55% of people had something. We don't know what it is, and we're going to outsource that to our radiologists, which is fine if our radiologists got their eye into ILD and so on and so forth. But this is a lot of people. And only 6 of them progressed radiologically over 6 years. And I think that's also important. So these, we have to frame all of this in these numbers. So there's a lot of people with something, but most people probably don't have anything that we need to worry about. But they're still going to come to our clinic because the default is to be cautious and conservative. When you look at the mortality, those who had an ILA with progression, defined as radiological progression. So a radiologist said, this got worse over the course of 2 scans. They did quite badly. Median survival was round about, it just about hits there on that curve. And this is the Framingham Heart Study. But the loss of lung function was 29 mils per year, which was significantly higher than the patients without ILA who lost 20 mils per year. But are you confident that your lung function technicians are going to be able to separate 9 mils per year, even though statistically that's a very small number and would not fit our current definitions of progressive pulmonary fibrosis, which require 2 out of 3 radiology, lung function, and symptoms. So we've got some issues here. Now it gets worse with the Reykjavik Ages study because they recruited a lot more people, 3,000, and obviously there's lots of Icelandic people, and genetically I'm Icelandic, so this is very close to my heart. 3,000 plus people, 5 years apart. 10% had an ILA on 1 scan. 44% of people had something. Almost half of these people had something on a scan. Many more of these progressed radiologically, but still not all of the patients with the indeterminate. They just ignored the indeterminate. But so 132, which is not 40% of 3,000, but it's 40% of those who had an ILA, improved and some got better. But the sort of risk factors for progression included MUC5B genotype, so the minor allele being present, increasing age, and male sex. So being older and being male are risk factors for ILA, risk factors for IPF, and MUC5B genotype. It's interesting that the odds ratio is just around about 3. which is what we see if we screen large data sets with physician diagnosis of IPF. Or if you look at cohorts, the risk allele gives you a 5-fold risk. But on a sort of broadly defined community physician-defined IPF, these odds ratios are slap bang in what we would expect for IPF. So are we actually seeing in something like the Reykjavik Ages cohort that ILAs are actually just early IPF and they've been misdiagnosed? And certainly if you look at their figures for, so the bottom graph is without fibrosis and the top is they split their ILAs into probable, possible, indeterminate, or UIP pattern. But basically what you see in the Reykjavik Ages cohort, if you've got UIP or you've got fibrosis, the median survival is pretty much slap bang in the ballpark for IPF. But because they didn't do lung function, and because it's a cohort study of the general elderly population, are they just doing what I did with my 2 original patients, picking up previously undiagnosed IPF? We will never know, because that's the trouble with these kind of population cohort studies. But in the UK, we did something at the Brompton, which was to look at our patients who were found to incidentally, so by definition, Fleischmann definition, have an ILA on their CT scans. How many of them would be, we consider what we think an ILA is, which is early, possibly non-progressive changes on the CT scan, which we need to think about, and those who have a disease which we need to do something about. And actually, what we were detecting on our lung cancer screening program was 2/3 of patients had disease. 1/3 of people had what we would call an ILA, or I think what intuitively we think an ILA is, which is someone who doesn't have symptoms, someone who doesn't have abnormal physiology, however we define that. 2/3 of them had a disease. Half of those had IPF, and the other half had what you might expect in a non-selected population, of whom a proportion went on to require treatment. So I think our nomenclature is poor as a community, and it hasn't been sadly made better by the current ATS guidelines. So what do we do? What do we need to do about ILAs? So we did a survey as part of my research professorship to find out what healthcare professionals thought and what patients and their relatives thought. So most healthcare professionals in the UK thought that ILAs were an incidental finding and were sort of comfortable with the Fleischner diagnosis. We did ask about screening, and I'll talk more about that in a minute. And the healthcare professionals thought that screening was feasible, but beyond that, the practical implications weren't really considered. And the interesting thing was about whether to do clinical trials, because the natural history was uncertain. So how do you do a clinical trial when you don't know when these people are going to get worse? And this was pre-nerandomilast, although I don't know if nerandomilast will make any difference. The side effects of antifibrotics were considered to, you wouldn't want to give this to patients if you didn't know they were going to get worse. Patients, as I said, they didn't really know much about pulmonary fibrosis at all, let alone interstitial lung abnormalities. They're very happy to think about screening programs and actually would like this to be encouraged. And the concept of early treatment was supported, but there were concerns about side effects and impact on quality of life. So interestingly, the patients were more sort of gung-ho than the physicians, who were largely conservative. So screening. This is from the original document in 1968, talking about screening for disease. And the whole point is that you have to be able to, you do this to prevent death or improve quality of life by detecting a condition at a stage that treatment can be effective. You have to be able to reach everyone in your target population, and it has to reduce the chance of people developing a serious condition or its complications. And it must provide an evidence base for people to make informed choices. So I put these up so we can think about these principles as we go through whether we should be screening for ILAs. That's not the same as what we currently do, which is we detect ILAs in people who are screened for other things, which I think is fine. So should we be screening for ILAs to treat progressive pulmonary fibrosis? So we'd obviously have to choose older people, and we may want to stratify by sex because the risk is increased in males. But you'd have to, these differences aren't big enough that you wouldn't screen women. And at what age cutoff would we use? What about other risk factors, smoking history? So I showed you that graph. You know, you're going to be screening, what, 50, 60, 70 million people in the US? It's a lot of people. We could do it we could stratify by individual risk, so patients with connective tissue disease or with family history, and I think that's reasonable. But remember, we're screening for an RD, we're not screening for an abnormality in those patients. And so when we think about our populations, where do we get our RLAs from? They are from patients who are having screening for other purposes. That is fine, but that is not the same as having a screening program for ILAs. And should we recommend screening people who are otherwise not having a CT? I think that's where the ATS guidelines are. That's where we get in a tricky position. Targeted screening, I think I would agree with. So an HRCT for someone who's got CTD, ILD, and they recommended HRCT for everyone over the age of 50 who had a first-degree relative with familial pulmonary fibrosis. And certainly there was no recommendation on everyone who was over 50 who had a relative with IPF. And I think that's fair. We're talking about a lot of people here. So I would kind of agree with the targeted screening approach. I'd kind of agree with the stratified screening approach. I wouldn't agree with the population-based screening approach. So we have to think about the risks and the benefit, you know, especially when we get all these people with indeterminate scans. Over 50% of patients who are screened based on Framingham and Reykjavik ages are going to have something. That's going to lead to a lot of anxiety and a lot of overtreatment for what benefit? So the ATS did recommend HRCT for people over the age of 50. I think this would be a disaster for everyone, honestly. I mean, I'm over 50. I have not had a CT scan yet. Maybe that's foolish of me, but I think this is just for population-based. I think that's a disaster, but they did not recommend MUC5B promoter variant testing or telomere length testing. We can, again, I think there are pros and cons of both of those. So if we think about screening, again, just from a general principle basis, we have to be able to provide a diagnosis once we screen someone. For 50% of people, they're going to have an indeterminate something. That's not going to be a diagnosis. That's going to be, there's something in your lung, we don't know what it is. And these guidance and protocols are critical for subsequent clinical referrals. So again, is your program ready to deal with 50% of people with a CT which says, we might have something, we don't know what to do about it? Well, again, good luck. Okay, that's not screening. That's individual choice. That's a different thing. So screening programs have to have links with appropriate treatment services. I think these are just generic principles. We have to have the capacity, and that means service capacity, staff, infrastructure, to diagnose and then treat screen-detected conditions, all screen-detected conditions. And then there should be systems in place to offer everyone with a screen positive result of diagnosis. So there's lots of practical stuff for ILAs and ILDs. So based on the ATS guidelines, this is what we do if we find something. Baseline lung function, FVC, total lung capacity and gas transfer. I think with TLC, I might argue with. CT scan every 2 to 3 years. That's a lot of CT scans. They're not recommending histology for ILA, but may be important for ILD. Again, it's a lot of biopsies potentially, especially if there's diagnostic uncertainty about the stuff. Is it an ILA? Is it not an ILA? Is it fibrotic ILA, not fibrotic ILA? And there was no recommendation for genetic testing, which is probably, in my opinion, the easiest, cheapest, and most cost-effective bit you could do. And this is their algorithm. I'm not going to go through them. They're there. These are the screening pathway algorithms. And that's the important thing there. They are recommending screening for ILS. And yet we don't really know what an ILA is. We all have our own interpretation, but you can't screen for an incidental. Well, you can screen for an incidental finding, but that would be madness. So I think this is very premature and outside of targeted screening for patients with familial disease or connective tissue disease. It's going to create work and anxiety, but maybe profit, which is something. So remember, purpose of screening is to find disease, pre-disease, or something that can be treated to prevent disease. Purpose of characterizing an ILA is to identify what is disease and treat at some point the risk benefit favors therapy. And these are very different. These are very different, and we'll go on. So I think we do not and we should not screen for ILAs. Because if we find an ILA, there are 4 things that may happen. This ILA may get better on its own. It may remain stable for the lifetime of the patient. It may progress to an ILD, but the ILA may already be an ILD. So it's the latter 2 that we need to focus on. The first 2, somehow we need to get them out of our service as quick as possible. Otherwise, the service will be overwhelmed and these patients will suffer unnecessary anxiety. So somehow we need to figure out how do we focus on 3 and 4. So there are different ways of risk stratifying. Fleischner guidelines in green, ATS guidelines in black and white. The only real things that are helpful, which aren't old age and male sex, are MUC5B promoter variant and telomere testing. And yet these are the 2 things they didn't recommend for their, for their screening protocol. And yet this might help us. If the minor allele is positive, it doesn't mean that their fibrotic ILA is going to progress, but you'd probably keep a closer eye on it because it's more likely than otherwise. Should we measure telomere length? Well, if there is concern about giving these patients immunosuppression, these are the data. The hazard ratio for progression is higher in people who with ILDs who have short telomeres. And this just shows that if you have MUC5B in a fibrotic interstitial lung disease, it behaves like IPF. These are data from Brett Lay and the chronic hypersensitivity cohort in San Francisco. That there's more MUC5B than you might consider by chance in fibrotic HP, and they behave like IPF. So I think actually measuring MUC5B helps. It's not a binary answer. It's not yes, no, but it helps. So if you're old, or male, you've had a cigarette in the past, and your MUC5B is positive, your fibrotic ILA is more likely to become something that you need to treat when the FVC drops. These are data from John Kropsky from his familial cohort, showing that epithelial biomarkers are more likely to be up in patients with disease that goes on to progress to be pulmonary fibrosis. So should we be looking at biomarkers and helping risk stratify? I mean, I think we should. The challenges with things like MMP7 and SPD, they're not routinely measured by quality assured company. So you have to have your own reference ranges in each lab, which is a challenge. We've done this in post-COVID stuff. This is work by Ian Stewart. Again, MMP7 is highly associated, elevated levels are highly associated with fibrotic looking residual lung abnormalities in people who've had COVID. So these are people who had CT scans 6 months after they were discharged from hospital with COVID. MMP7 is up. The good news about this is this company who we worked with make biomarkers for clinical chemistry labs. So it's possible we'll soon have a standardized QC'd MMP7 measure that people can use in their hospital lab, because that's really why we haven't. And this just shows that MMP7 is associated with both IPF progression and mortality. A 1 standard deviation increase in MMP7 means that you've got a 25% increased chance of progressing and dying within the next year. So we can use these biomarkers, and I showed this earlier, showing CA19-9. So I could see a situation where you have an ILA, you're MUC5B positive, you're old, you're male, your MMP7's up, your CA19-9's up. Challenge with CA19-9 is you've got to check the pancreas out. Even though the positive predictive value of the CA19-9 is so low, you're going to kick yourself if that patient then dies of pancreatic cancer. So I think we can risk stratify with biomarkers. So what about treatment? So this is the key question for screening. If we identify these patients earlier, will we improve outcomes? And then what do we, how long should we follow them up for, and what should we do? So as part of our UK-wide survey, we asked physicians, what would they do? And you can see just by all the different segments, they would all do wildly different things. Every 12 months CT scan, no CT scanning every 2 years. This is not a pathway post-screening. How long do you follow up for? For more than 5 years? Again, the practice was highly variable because we don't know the answer. None of these are wrong. But the problem is that we are told that antifibrotics slow the progression of disease, and they do, if you have IPF, and you follow them for a year in a clinical trial. So there is no doubt that this slows progression. And now nerandomilast also slows progression. So we are told by a variety of people that the sooner we start treatment, the better. Therefore, if we identify a fibrotic ILA, which we think is going to progress, it stands to reason that we should start them on treatment as soon as possible. But, so I took this picture last night from the Yale Museum of British Art, which I was very pleased to see. I've never seen boats like this in Britain, and they normally are on water. So the first thing we have to consider is survival bias. So we published this a couple of years ago now, but basically if you follow people up for longer than a year, survival bias starts to kick in. So the missingness, people who die have lower lung function. And so what you're left with is a bunch of people who have good lung function because they're alive, because all the people with poor lung function have died. And the longer you follow people up, the more of a concern this becomes. But this is what's really beginning to worry me. So these are data from the Isabella study. And if you look at the placebo arm here, so these are patients who are not getting, it doesn't matter, there's no effect, but the placebo arm, and you have on pirfenidone, on nintedanib, or no treatment. The patients with the least loss of lung function are the patients who are not receiving pirfenidone or nintedanib by 40 mils of FVC. This is greater than your ILA loss. So this is the problem. So maybe it's just the Isabella study. This is fibronectin. The same pattern emerges. That's patients not receiving any background therapy 150 mils loss over a year. That's nintedanib 190, pirfenidone 197 mils. Okay, so it's two studies. This is Teton. Same thing happening. This is no background therapy, 100 mils lost, 107. On nintedanib, 115, on pirfenidone, 187. So there's 3 prospective clinical trials. Now, we did write, well, we didn't. Letitia, Quano, Dorado, Athol, and Manuela, who you will know well from Yale, wrote a letter to JAMA after the Isabella study to highlight this disappearing treatment effect, what's causing it. The response from the authors of the Isabella study, of which I was one, but didn't respond to the letter, was that they're just a different population of patients. Oh, they may be, but I think this is a problem. I think the fact that patients who have been on, presumably they've been on nintedanib and pirfenidone for a long, long time to get into the study. Maybe all the people responding to nintedanib and pirfenidone are not being recruited into the study, but this is still a substantial number of people who are doing sufficiently badly to be entered into a clinical trial, and we don't know why that is. Now, it might be a statistical quirk, it might be patient heterogeneity, or it might be that we develop resistance to antifibrotics, as we do in other conditions where you give therapy forever. And if that's the case, then we have a problem, especially if the argument is we've got to start the antifibrotic as soon as possible. Because what happens if they're resistant by the time the FVC starts to accelerate? So I don't know the answer, but I think it's a question that we need to find an answer to. And I haven't looked at these were just the 3 studies that fell into my lap last night. I mean, I knew about Isabella, but so I think it's, there is something going on and we need to understand that. So we really need to understand progression of disease. The rate of progression is critical, I think. If you're progressing at 9 mils a year, that's probably not enough to upset a patient about. Current antifibrotics are poorly tolerated, expensive, and have no long-term data on efficacy, and limited long-term data on adverse effects, especially in ILA. So before we start giving everyone an antifibrotic at the first whiff of fibrosis on a CT scan, I think we need to have a little bit more understanding. Clearly, if you've got IPF, symptoms, lung function, that's a different issue, but I just think we need to be maybe not rushing straight for the OFEV, and the first time you see a CT scan which shows a little bit of fibrosis. Again, there's not, I wouldn't criticize anyone for doing it, but I just throw out there a word of caution. Therefore, the timing and initiation of therapy remains a decision based on individual discussion between the physician and the patient. I think that's the critical point, especially for incidentally found lesions. These people thought they were well, they've had a CT scan for, heart disease or something, and then you've told them they've got fibrosis, they look on the internet, they've got 3 years to live and they're on an antifibrotic. I think, so we have to have these careful discussions. And these discussions are much easier when we know the data about progression, survival from epidemiological studies. So the way I approach an ILA is, is this an ILD? Because then it's kind of easy. Yes, refer management as appropriate for that ILD. The next decision is this ILA going to get worse? And I think this is where we are struggling. So we know based on age, sex, MUC5B, and whether there's fibrosis or fibrotic ILA is more likely to progress than a non-fibrotic ILA. Although the definition of progression is still sketchy because it's radiological progression for ILAs. PPF is a different definition. And then, in some patients who've obviously progressed, you can't call them progression. But if you have someone at high risk of progression, you would refer and monitor. But how often do you monitor that? We don't know. Again, my ballpark is a CT scan every year, but some services would do. It depends on what you can do in your location. Then, the question is, has the patient progressed? Because that's when you're going to start to think about treatment rather than monitoring. But we haven't got a good definition. I wouldn't say a 9% loss of FVC constitutes progression, but I could be wrong. Biomarkers may help. And do we wait 5 years? Not if we believe the Reykjavik ages data, because if you wait 5 years, then you've lost 50% of your severe patients. And then decision 4, should therapy be offered? Well, again, that's a discussion between you and your patient. So my very unhelpful conclusions are that the nomenclature is unhelpful and we need to do better. But ILAs are a starting point and not a diagnosis. They get you into the system, but the system isn't set up for how to deal with them just yet. We are not and should not be screening for ILAs. In certain situations, we are screening for ILDs, but there is no point screening for an incidental or non-progressive or a finding that you don't know what to do about and you can't treat yet. It just breaks all the principles of screening. However, we should potentially adopt stratified targeted screening for certain high-risk groups, and I think that's fine. But we really need to understand the natural history of this. Because knowing when to intervene and with what is going to be critical. And knowing how it evolves is really important. So yeah, I'll stop there. I think I'm just within time. And this is my lab group, Ali and Louise, who did all the genetics and stuff. So thank you. And if you've got any questions, I'll take them.
So thank you for the informative and quite provocative presentation. I think we all learned a lot, and I'm looking forward to questions. Dr. Mathey.
If I gleaned it right, you want to see MUC5B and perhaps epithelial markers as an approach here. You could elucidate that a little more?
I think there would be value. Certainly, I think I wouldn't be able to say, hand on heart, that if we do a MUC5B test and get the result, that it will impact the individual patient, but it will help risk stratify. And and certainly from patients with ILD, what we're seeing is there's a lot of MUC5B positivity, which is in keeping. The minor allele frequency is 15% of the general population, but you see it in 60 to 70% of ILD patients. So it adds value in terms of risk stratification. Would we be able to do anything about it? No. Would it have any implications for family? No. But we still ask people whether they have smoked. Even though we're not going to do anything about it now, we asked for that information. I agree that asking someone if they smoked is a lot cheaper, easier, and quicker than sending a blood test off for MUC5B. But actually, sending a blood test off for MUC5B isn't going to break the bank of most services, unlike following up for 10 years with annual CT scans and the associated risk of radiation, etc. So I would, again, I think it's something that we could do. I don't think it's something that we have to do, but I think it would help.
So actually, following up on Richard, is actually, wouldn't the negative predictive value of a negative MUC5B genotype and a low CA19-8 be actually really beneficial? Because I think we tend to look about what's the value of positive results. But the truth is that if you have a MUC5, the wild type allele, and you have again, the problem with CA19 is that what do you do when it's high, right? But if it's low, and I think, Yeah, so I love this definition. I think that's brilliant. And I think if we could convince some people to think about it the other way around.
I agree. If you had a, yeah, and in terms of if you were going to risk stratify your whole service, especially with all these indeterminates,
Yeah.
which are probably more or less common than we think on a proper CT scan. But I think, yeah, it would make a huge value to our service over and above, following everyone up.
Now, the other thing that I want to ask you, because I love the way you said, okay, we should not screen for an incidental finding, we should screen for a disease, right? So what do you think about, David Schwartz in 2005 introduced preclinical pulmonary fibrosis? What do you think about this term?
I think it's wrong. I remember the arguments because I was one of the reviewers between the co-authors of different papers arguing with each other, which is really funny. You get that sort of behind the scenes disagreement. But I think he's wrong because we don't know if it's preclinical disease. I mean, you're not 100% wrong. Some of it will be. But the assumption that this is all going to become clinical disease is definitely not borne out by the data. And so we have to be careful. Some of it will be for sure.
Dr. Siegel?
Thank you very much. So I'm presuming even if a lot of the patients with ILA don't actually have a disease, there's still some problem or something in their history that explains why the lung developed interstitial abnormalities. And it made me think that in my clinic, I have a number of patients who have had a well-defined history of some kind of discrete injury to their lung. Like I'm seeing them after ARDS, or I'm seeing them after COVID, or just some bad pneumonia. And in a couple of these cases, I've been surprised where I thought that they would have a completely static clinical course, like a one-time insult, don't worry about them again. Years later, I've started to see some progressive findings, like the development of pulmonary hypertension, or even worsening of their CT scans, suggesting progressive fibrosis. So I'm wondering if that sheds any light on some of the topics you're talking about today, because I wonder if we could uncover some connection between discrete insults and then setting off a cascade that might only manifest itself years later.
So 100%. And I think, that was exactly my thought with COVID. I thought we are now going to have this, wonderful, quote unquote, natural experiment where we give the whole world acute lung injury at the same time. We're going to see what happens, whether we like it or not. And what we found looking at so the post-hospitalized data is about 11% of people have something. What we don't know is how many of them had something before for a non-COVID related injury. And but the demographics of people were quite different. So they were younger, there were more women. So we don't think it was all undiscovered ILA. And when we looked in the community patients, it's still quite high given the number of people exposed to COVID. So people who didn't go into hospital, but it was about 5% of people. So I think you're absolutely right that some people are going to get an insult. And as we see from the ARDS literature, most of those people will remain static. They never come back to normal, but most of them will remain static, but proportion go on and develop progressive pulmonary fibrosis following their ARDS. And we've seen this in our post-COVID clinics in the UK. A small proportion do go on and get this horrible, remorseless, slightly different, but fibrosis that eats up the lungs. And we've got some really tragic cases. But it's not everyone, and fortunately it's the minority. But the trouble is, how do you organize a service if you're always worried, if you've got so many patients and you're looking after all of them just to look out for a real minority, especially when we don't quite know what the minority is, or how long it's going to be, or what the trigger point is, or if starting treatment before symptoms emerges is important. Because the easiest thing to do from a sort of public health point of view is say, go home, if you get breathless going up the stairs, you develop a cough, come back and then we'll start treatment. Now that only doesn't work if starting treatment before then makes a material difference to outcome. And we just don't know that yet. And I think that's what we're all grappling with, because intuitively, if you have drugs which slow down progression and that effect is lifelong and the side effects aren't too bad, yeah, nerandomilast perhaps, that's important. But I think we just don't know. And if we just blindly accept, 12 months worth of data and some off-label or open-label extensions as, this is going to work forever, especially if some of the data suggests that these antifibrinogens don't work forever, we're going to run into problems.
We have time for one last question from Dr. Manning, and then we will adjourn.
Thank you for a wonderful talk. So oncologists and radiologists the last few years have been having a lot of data and discussions and modeling on the effects of CAT scans, and are predicting that there's a small but meaningful risk in the number of malignancies due to use of CAT scans. And I'm just wondering, in the studies, that if has anyone been looking at ILAs and kind of measuring the dosimetry and trying to predict the dose effects of CAT scans? Because could this actually be harmful by doing large population screening with frequency that you're describing?
So I'm not familiar with that, because I'm aware of the literature looking at the harm of CTs in patients, because we're all told about it all the time, and I guess from an IPF point of view, we don't worry about it because the mean life expectancy is so small that if they live long enough to get a radiation-induced or a radiology-induced lung cancer, then they've actually done pretty well. But I totally take your point. Large populations of younger people we have no idea what their natural history is. So we haven't looked because we haven't started screening these people yet. And that's just another tick in the let's not screen these people until we have a very clear idea that our intervention is going to make a material difference to their outcome. And that's just another argument against that at the current time.
Well, thank you very much.